Welcome to the deep dive. We take complex source material and really boil it down for you. Today, it's a really important one, the chapter on respiratory drugs from Lilley's Pharmacology for Canadian healthcare practice.
Right, and our job here is to cut through the density. We want to give you a clear, kind of actionable study guide. We'll hit the drug classes, how they work, what they're used for, and crucially, the nursing stuff. Safety, what to watch out for, focusing on the big ones, asthma and COPD, lower respiratory tract diseases.
Okay, lower respiratory tract, so that's the structures inside the chest, right? Trachea, bronchi, those tiny alveoli. That's where things like asthma and COPD really take hold. And you mentioned a shift in thinking.
Yeah, a big one. Historically, it felt like it was all about just stopping the bronchospasm, the tightening. But the
Yeah.
source really hammers home that the modern approach, well, it zeroes in on the inflammation. That chronic underlying inflammation is the real target now.
Interesting. So manage the inflammation, and maybe you break the cycle of attacks.
That's the idea. You can't just keep putting out fires without dealing with what starts them.
Okay, let's dig into the conditions themselves then. Starting with asthma. The text calls it heterogeneous, meaning it shows up differently in different people.
Exactly. But the core features are usually there. That chronic airway inflammation we mentioned, the smooth muscle, getting twitchy spasticity, and yeah, too much mucus sputum production.
And then there's the really scary version, status asthmaticus.
Right. That's when an asthma attack just goes on, it's prolonged, doesn't respond to the usual rescue meds. Definitely life-threatening.
So how does this actually happen? What's the pathophysiology?
Well, think of it like your immune system overreacting. An allergen could be pollen, dust mites, whatever gets in. This triggers your body to make specific antibodies, IgE antibodies, immunoglobulin E.
Okay.
These IgE antibodies then sort of stick themselves onto mast cells, which line your airways. They just sit there waiting.
Waiting for the next time you encounter that allergen.
Precisely. And when that happens again, bam, the mast cells basically explode, well, degranulate. They release a whole bunch of inflammatory chemicals. Histamines, leukotrienes are the big ones here.
And these chemicals cause?
Immediate trouble, swelling in the airway lining, and that smooth muscle just clamps down hard. Bronchoconstriction, that quick reaction, that's the early phase response.
But it doesn't stop there, does it? There's a later reaction too.
Right, the late phase response, this usually peaks, maybe 5 to 12 hours later. It's more about prolonged inflammation. Different immune cells, like eosinophils, come flooding in, and this makes the airways super sensitive, hyper-responsive.
So things that aren't even allergens can trigger problems then.
Yeah, exactly. Like cold air, maybe strong smells, even exercise. The airways are just primed to react because of that underlying inflammation from the late phase.
Okay, let's switch gears to COPD, Chronic Obstructive Pulmonary Disease. How's that defined now?
The definition's been updated following the GOLD guidelines. That's the Global Initiative for Chronic Obstructive Lung Disease. They now define it more broadly. It's a heterogeneous lung condition, again that word, with persistent airflow problems. Often gets worse over time. And it's caused by issues in the airways, the alveoli, or both.
So let's focus on the old terms like emphysema or chronic bronchitis.
Yeah, those describe types of damage, but the core definition now really focuses on that persistent, measurable airflow obstruction. It kind of brings it all under one umbrella.
Makes sense. Okay, so we understand the battleground asthma and COPD. Let's talk weapons, the drugs. You mentioned relievers versus controllers. Let's start with the bronchodilators, the relievers, the ones that open things up.
Right. 3 main classes here. First up, probably the most common, beta-adrenergic agonists.
How do they work?
They target beta-2 receptors. These are specific adrenergic receptors found heavily in the smooth muscle of your lungs. Stimulating these beta-2 receptors kicks off a chain reaction. It activates an enzyme, adenylate cyclase, which ramps up production of something called cyclic AMP, or CMP. And the key thing to remember is more CMP equals smooth muscle relaxation. Airways open up, bronchodilation.
Got it. CMP is the relax signal.
Yeah.
And there are different types of these beta agonists.
Yep. 2 main flavors. You've got your SABAs, short-acting beta agonists. Think salbutamol. Brand name Ventolin is common. These are your rescue inhalers. Quick onset for stopping an attack that's happening right now.
And the other type?
LFA's long-acting beta agonists, like salmeterol. These aren't for rescue. They're for maintenance, long-term control, and really important, they're almost always used with an inhaled steroid, not usually alone for asthma.
Okay, LBs for maintenance, often combined. Now, you mentioned beta-2 selective drugs like salbutamol.
Yeah.
What's the difference with non-selective ones?
Good question. Non-selective agonists like epinephrine, think EpiPen, they hit multiple receptors. Alpha, beta-1, which is mostly heart, and beta-2 in the lungs. Hitting beta-1 is why epinephrine jacks up your heart rate and blood pressure so much. Causes tremors, too.
So the selectivity of drugs like salbutamol aims to avoid those heart effects.
Exactly. They mostly target beta-2 in the lungs. But, and this is key, if you overuse them, take too many puffs. At higher doses, they can start hitting those beta-1 receptors a bit too, so you can still get some tachycardia, some tremor, especially with overuse.
Okay, important distinction. Next bronchodilator class. Anticholinergics. What are these about?
These are also called muscarinic antagonists. Think ipratropium or the longer-acting tiotropium. They work by blocking acetylcholine. Acetylcholine is the neurotransmitter the parasympathetic nervous system uses to, well, constrict airways and ramp up secretions.
So blocking acetylcholine prevents that constriction signal.
Right. It stops the tighten up message, leading to indirect dilation. And they also help dry things up a bit, reduce secretions, which is often a big problem in COPD.
If they cause dilation, why aren't they used for rescue like the SABAs? You mentioned they're more for prevention, especially in COPD.
Yeah, it's about timing. Their effect comes on much more slowly than a SABA, and it lasts longer. So totally wrong for an acute attack where you need airways open now. They're purely maintenance controllers.
And there's a specific warning about how some of these are packaged.
Oh, yes. Crucial safety point. Some products, Spirva is a common example, come as capsules. But these capsules are not meant to be swallowed. They go into a special inhaler device that pierces the capsule, and you inhale the powder. Swallowing them does nothing and misses the whole point. Big potential for error there.
Good flag. And side effects. Since they block acetylcholine?
Predictable anticholinergic effects. Dry mouth is common, maybe some throat irritation, potentially constipation or urinary retention. So you'd be cautious using them in people who already have issues like, say, glaucoma or an enlarged prostate, BPH.
Okay, one more bronchodilator group. The Xanthine Derivatives. Theophylline is the main one.
Yeah.
He said these feel a bit like the Wild West.
Yeah, they are. Trickier. Clinically complex. Their mechanism is different again. They inhibit an enzyme called phosphodiesterase, or PDE. PDE is what normally breaks down CAMP.
So inhibiting the breakdown enzyme means more CAMP hangs around.
Exactly. More CAMP, more bronchodilation. But that's not all they do. They also stimulate the central nervous system and the heart. They make the heart beat faster and stronger, positive chronotropy and anotropy.
And the Wild West part. The danger.
It's the narrow therapeutic index. This is critical. The effective dose is really close to the toxic dose. You need to keep blood levels within a very specific, narrow range. The source gives around 55 to 110 micromoles per liter. Regular blood tests are essential.
What happens if levels get too high?
Serious toxicity. Seizures. Dangerous heart rhythms like ventricular arrhythmias. Really bad news. Plus, interactions are a huge issue. Smoking, for instance, actually lowers theophylline levels because it speeds up its metabolism.
Oh, wow. So a smoker might need a higher dose, but if they quit.
Their levels could shoot up into the toxic range. Conversely, things like caffeine or other stimulants can worsen the CNS and cardiac side effects. You have to be so careful with these.
Okay. Definitely a high alert drug. So those are the relievers, the bronchodilators. Now let's tackle the controllers, the non-bronchodilating drugs that go after the inflammation itself.
Right, the anti-inflammatory team. First up, Leukotriene Receptor Antagonists, or LTRAs. Montelukast is the common one here.
Leukotrienes. Those were the inflammatory chemicals released by mast cells, right?
Yep, key players in that inflammatory soup. LTRAs work by basically blocking the docking station, the specific receptor, LTD4, that leukotrienes use to cause trouble. By blocking the receptor, they prevent leukotrienes from triggering inflammation, mucus production, and bronchoconstriction.
Again, these are controllers, not for acute attacks.
Absolutely. Prophylaxis. Long-term treatment, usually for asthma. You won't see improvement right away, maybe takes about a week. Side effects are generally things like headache, maybe some nausea or diarrhea.
Anything serious to watch for?
Yeah, two key things. One is liver function, need to monitor liver enzymes sometimes. And the other, quite distinct, is reports of neuropsychiatric effects like nightmares or agitation, especially noted in some children, but adults too.
Interesting. Okay, now for the heavy hitters in inflammation control. Corticosteroids, also called glucocorticoids.
These are really the cornerstone for managing persistent asthma. Their main job is anti-inflammatory. They work in a few ways, but a key one is stabilizing cell membranes. They stop cells like mast cells and other leukocytes from releasing all those inflammatory and bronchoconstricting substances.
So they calm everything down at the cellular level.
Pretty much. And they have another important effect. They actually make the airways more responsive to those beta-agonist bronchodilators we talked about earlier. They kind of boost the effect of the rescue inhalers.
How are they usually given? Inhaled or pills?
Depends on the situation. For long-term maintenance, inhaled corticosteroids are preferred, drugs like fluticasone or butanide. Using an inhaler keeps most of the drug in the lungs, which minimizes systemic side effects throughout the body.
But sometimes you need systemic treatment.
Yes, for severe flare-ups or exacerbations, doctors might prescribe oral steroids like prednisone or even IV ones like methylprednisolone in the hospital to get a powerful body-wide anti-inflammatory effect quickly.
There's a really crucial teaching point for anyone using an inhaled steroid, isn't there?
Oh, absolutely non-negotiable. Rinse and spit. After using the inhaler, you must rinse your mouth thoroughly with water and then spit it out. This washes away any drug lingering in the mouth and throat, preventing fungal infections, specifically Candida albicans or thrush. Very important.
And what about stopping systemic steroids, like prednisone pills?
Another huge safety alert. You never stop systemic steroids abruptly, especially after long-term use. The body stops making its own natural cortisol when you're taking them. Stopping suddenly can cause adrenal suppression, leading to an Addisonian crisis, which can be life-threatening. They always need to be tapered off slowly under medical supervision.
Got it. Okay, before we move to nursing implications, any other controller drugs we should quickly mention?
Yeah, the chapter touches on a couple others. There's roflumilast, which is a PDE4 inhibitor, different from theophyline's PDE, specifically targets inflammation in COPD. And then there's omalizumab. It's a monoclonal antibody, a biologic drug.
How does that one work?
It's quite clever. It actually binds to those IgE antibodies before they can attach the mast cell. So it intercepts the very first step in that allergic cascade we discussed, used preventatively for moderate to severe allergic asthma.
How's it given?
Subcutaneous injection, usually every few weeks. But because it messes with the immune system, there's a black box warning for anaphylaxis, which can sometimes be delayed, so patients need careful monitoring.
Okay, quite the arsenal of drugs. Let's tie this all together now with the nursing process. How do we apply this knowledge at the bedside? Starting with assessment.
Key priorities. Always assess respiratory status, obviously, but look for subtle clues. Restlessness, for example, can be the very first sign of hypoxia, low oxygen. Don't wait for the O2 sat to drop. You absolutely need to ask about and document smoking status. Remember that theophylline interaction? Huge implications. And check for those underlying conditions that might be contraindications, especially for anticholinergics, glaucoma, BPH.
Right. Moving to implementation, putting the plan into action. Patient teaching is massive here, right? What's the rule for using multiple inhalers?
The sequence is vital. You have to get this right. If someone's prescribed, say, a SABA or LABA and a corticosteroid inhaler, bronchodilator first, always. Open the airways, let that drug work for a few minutes, then use the corticosteroid inhaler. This allows the anti-inflammatory medication to get deeper into the lungs where it needs to work, now that the passages are more open.
Makes perfect sense. What about the inhaler technique itself?
Technique is everything. With meter-dose inhalers, the puffers, always encourage using a spacer device. Seriously, studies show up to 70% of the drug can just end up in the mouth or throat without a spacer, never reaching the lungs. Spacers dramatically improve delivery.
And timing between puffs?
Yeah, wait 1 to 2 minutes between puffs of the same drug. Gives the first puff a chance to work a bit. If using different inhaler drugs, wait maybe 2 to 5 minutes between them, following that bronchodilator first rule.
Any specific advice for taking theophylline, besides the blood tests?
Adherence is key because of that narrow window. Take it exactly as prescribed, around the clock, to maintain steady levels. And most oral forms, especially the long-acting ones, should not be crushed or chewed. It messes up the timed release.
And for corticosteroids?
Consistency. These are maintenance drugs. Take them every single day, even if you're feeling perfectly fine. Skipping doses lets that underlying inflammation creep back in.
Okay. Finally, evaluation. How do we know if the treatment plan is actually working?
We look for improvement, both subjective and objective. Does the patient feel less short of breath, less wheezy, less anxious? Are they tolerating activity better? But we back that up with data. Improved oxygen saturation levels, clearer lung sounds. And those objective measures are theophylline levels, if applicable, therapeutic. Are the patient's peak flow readings improving or staying stable? Peak flow meters are great for tracking lung function at home.
So stepping back from all this detail, the big picture from this chapter seems to be about managing a chronic condition through a careful balance, doesn't it?
Absolutely. It's this constant interplay between needing immediate relief, sometimes that's your SABAs, maybe theophylines in certain situations, and the crucial long-term control of inflammation using steroids, LTRAs, LABAs, anticholinergic.
It really underscores how complex managing something like asthma or COPD is.
It does. And it leads to a really practical thought for everyone listening. Given how vital technique and adherence are, how much of successful management comes down to excellent patient education and reinforcement versus just, chasing the newest drug. Something to really consider in practice.
That focus on the patient's role, their technique, their understanding, it's often the deciding factor, isn't it?
Yeah.
Well, this has been incredibly thorough. Thank you for helping us navigate this dense chapter and extract the absolute essentials.
My pleasure. It's complex stuff, but breaking it down like this hopefully makes it much more manageable for studying and for clinical practice.
Absolutely. Thanks again. And thank you for joining us on the Deep Dive. Until next time, stay informed.